morning. I thank Tamil Nadu IRA Coimbatore subchapter for giving me this opportunity. Today, we are going to see a lot of interesting topics in cardiac radiology. So first, I will start with CT anatomy of coronary arteries. The main objectives in my talk are to identify the coronary arteries and their major branches, to determine the coronary artery dominance. So what is dominance? Then to identify the common anatomical variants of coronary arteries and few hemodynamically significant anomalies. In this talk, I will be presenting mainly in workstation software so that you can understand the anatomy in real time. Before going to the coronary artery anatomy, I will discuss about anatomy of cardiac chambers and other related structures. I am scrolling craniocaudally. First, this is ascending aorta, and this is main pulmonary artery dividing into right and left pulmonary artery. As I come down, so this triangular shaped structure is right atrial appendage, and this is left atrial appendage, and this is right ventricular outflow tract, RVOT. As I come down, and this is right atrium, which is located on the right side. It is anterior, and here you can see left atrium, where you can see the pulmonary veins opening into the left atrium. So it is on the left side and it is posterior. As I come down, so this is a kind of four-chamber view. You can see left atrium, right ventricle, left ventricle. Right ventricle is anterior, left ventricle is posterior. Now we are having groove between right and left ventricle. This is called interventricular groove. So in the cranial aspect, this is anterior interventricular groove in the cranial aspect. As I go to the caudal aspect, or as I go to the inferior aspect of the heart, this becomes posterior interventricular groove. So in the cranial aspect, it is anterior interventricular groove, and in the inferior aspect, this is posterior interventricular groove. Now there is a groove between left atrium and left ventricle. This is left atrioventricular groove. Similarly, there is a groove between right atrium and right ventricle. This is right atrioventricular groove. So this is left atrioventricular groove and this is right atrioventricular groove. As I go to the inferior aspect, this right atrioventricular groove continues, and this region is inferior aspect of right atrioventricular groove, and it reaches to a point. This is crux. So crux is nothing but the point where inferior aspect of the right atrioventricular groove meets posterior interventricular groove. So this point is called crux. The importance of the crux I will explain later. The exact opposite point or exact diagonal point of crux is apex. So this is apex, which is directed towards left side. Now this is left ventricular outflow tract, and this is the aortic root. Now this point, so the point where aortic valves attaches to the aortic wall, this is called aortic annulus. The portion which bulges out, this portion is called aortic sinus or sinus of Valsalva. That is narrow portion, or the portion between sinus of Valsalva and ascending aorta. This is called sinotubular junction. So this is aortic annulus, this is aortic sinus or sinus of Valsalva, and this is sinotubular junction. Now, if you take exact cross-sectional cut at the level of aortic sinus, you will get image like this. Okay. So here you can see three cusps. So these This portion is called cusp. So you can see three cusps. Now we have to name the cusp. So the cusp which is towards interatrial septum. This is left atrium, this is right atrium. This is interatrial septum. So the cusp which is directed towards interatrial septum is non-coronary cusp. The cusp which is anteriorly located is right coronary cusp. The cusp which is posteriorly located is left coronary cusp. Okay. Now we will see the anatomy of left coronary artery. This is left coronary artery. Left coronary artery arises from left coronary sinus and it travels for a shorter distance between right ventricular outflow tract and left atrium. Then immediately it bifurcates into LAD and LCX. So left anterior descending artery and left circumflex artery. In few cases, it can trifurcate. So in that cases, the third artery will be ramus intermedius. So here we are seeing bifurcation. So the artery, this is left anterior descending artery, which runs in the anterior interventricular groove. And it reaches the apex of the heart. Then it curves around the apex for shorter distance. Depending upon the length of LAD, it can be classified into type 1, type 2, and type 3. Type 1 LAD terminates before the level of apex, and type 2 LAD will terminate at the level of apex, and type 3 LAD, which is more common, will reach the apex, then it turns around the apex for a shorter distance. Now we should see the branches of LAD. These are diagonal branches. The diagonal branches runs towards the left side and it traverses and it runs towards free wall. So these are diagonal branches. Now these branches which runs towards the septum, okay, these branches are called septal branches. So these are diagonal branches which runs towards the free wall and these are septal branches which runs towards septum. Now we'll see about LCX, left circumflex artery. This artery runs in the left atrioventricular groove and gives off obtuse marginal branches. So this branch is called obtuse marginal branch or OM branch, which runs in the left ventricular free wall. Now we'll see about right coronary artery. This is the right coronary artery which originates from right coronary sinus and it gives off branches. So this is conus branch. You are seeing conus branch which curves around the right ventricular outflow tract. And this branch is branch to SA node which runs towards left atrium. So this is branch to SA node. The next branch is AM branch called acute marginal branch which runs along the surface of right ventricle. Then this right coronary artery reaches the crux of the heart. Then it bifurcates. So the right coronary artery reaches the crux and it bifurcates into PDA. This is posterior descending artery which runs in the posterior interventricular groove. This is PDA. And the second artery is posterolateral branch. This branch is posterolateral branch. Now, what is the importance of crux? The artery which supplies PDA, that is the dominant artery. In this case, right coronary artery gives rise to PDA. So this is right dominant. In few cases, left PDA arises from left circumflex artery. That is left dominant. In few cases, both artery will supply PDA. That is codominant. So that finishes the coronary artery anatomy. Now we will move on to common anatomical variants and a few hemodynamically significant anomalies. Before that, we will see the blood supply to the heart, the area of distribution. Right coronary artery supplies right atrium, greater part of right ventricle, except the area adjacent to anterior interventricular groove. Small part of left ventricle adjacent to posterior interventricular groove. Posterior part of interventricular septum. Whole conducting system of the heart is supplied by right coronary artery except a part of left branch of AV bundle. So blood supply by left coronary artery. It supplies left atrium, greater part of left ventricle except the area adjacent to posterior interventricular groove, small part of right ventricle adjacent to anterior interventricular groove, anterior part of interventricular septum, a part of left branch of AV bundle. So this is the common pattern. So the blood supply is variable. This is the common pattern. Inferior wall is supplied by right coronary artery. Lateral wall will be supplied by LCX. Anterior wall will be supplied by LAD. Now, the classification of congenital anomalies. They are classified into anomalies at origin, anomalies at course, anomalies at termination. Now, this is high takeoff. Here you can see the coronary artery arises superior to the sinuses of Valsalva. This is sinus of Valsalva, but usually it should arise at this point, but here it arises superiorly at the level of sinotubular junction. So this is high takeoff. Now, multiple ostia. Sometimes coronary artery arises with multiple ostia. For example, conus branch will arise from right coronary sinus with separate ostia. Sometimes LCX will be absent. Left coronary artery will be absent. Instead, LAD and LCX will be arising from left coronary sinus with separate ostia. Instead of single ostia, they will arise from separate ostia. Now, this is single coronary artery. Now, the high takeoff and the multiple ostia, they are considered to be benign one because they won't cause any hemodynamically significant problem. But we have to mention because it will be useful to cardiologist before cannulation. This is single coronary artery. There will be only one coronary artery arising from any sinus, which bifurcates into RCA and LCX. Then it will supply the heart. Now this is Alcapa. Anomalous origin of left coronary artery from pulmonary artery. This is a malignant anomaly. The problem with this is coronary artery arises from pulmonary artery. Pulmonary artery belongs to low pressure system. So here coronary steal phenomenon will occur. The blood flow occurs retrograde from the coronary artery towards pulmonary artery. So there will be myocardial ischemia. Now we will see about origin of coronary artery from opposite sinus or non-coronary sinus. So in this condition, you have to see the course of the artery. For example, in the first image, you can see interarterial course. The left coronary artery arises from the right coronary sinus and it traverses in the interarterial region. So the problem with this, in case of acute stress, aorta and pulmonary artery will enlarge. So that will compress the artery. So that will lead to myocardial ischemia. The rest of the course are considered to be benign. So this is pre-pulmonic, this is retroaortic, and this is subpulmonic or septal. So only the interarterial course is considered to be hemodynamically significant one. So in this image, you can see left coronary artery arising from right coronary sinus with interarterial course. Next, anomalies of course. In this, we are having myocardial bridging. Myocardial bridging is nothing but a portion of myocardium will be portion of myocardium will cover the LAD. So the common vessel involved will be LAD, and usually the mid segment will be involved. If myocardial bridging is there, we have to see whether that is superficial or deep, whether that is short segment or long segment, whether that is associated with luminal narrowing. If there is superficial bridging or if there is short segment, then it is considered to be a benign anomaly. But if there is a deep bridging means more than 2 mm of myocardium will cover the vessel. So if there is a deep bridging, if there is a long segment involvement, if there is luminal narrowing, then that is considered to be a hemodynamically significant one. Then duplication of arteries. This is a benign one because sometimes we will see 2 arteries. Next, anomalies of termination. Here we are having coronary artery fistula. So the coronary artery will dilate and tortuous, and it will opens into some vessels. For example, in this image, you can see the coronary artery opens into main pulmonary artery. And another example, here coronary artery opening, we can see the coronary artery opening into coronary sinus. So these are the few examples of anatomical variants and hemodynamically significant anomalies. So one more thing is that is called extracardiac termination. Here the coronary artery will opens into extracardiac vessels like bronchial arteries and internal memory arteries. So in this condition, we have to see the pressure gradient between the two systems. So to conclude, I have covered anatomy of coronary artery and their branches. I have covered the blood supply of heart. I have covered dominance, then hemodynamically significant anomalies. So these are the list of anomalies which are considered to be hemodynamically significant. Anomalous origin of left coronary artery from pulmonary artery. So the interarterial course, single coronary artery with interarterial course, congenital coronary artery fistula, myocardial bridging with deep involvement, long segment involvement with luminal narrowing. Thank you.